Okay.
But you just, it's how they grind them is the difference, right? What you're missing probably in your skates is the toe pick. So it's a different, it's a completely different motion, right? So instead of like figure skaters.
Everybody getting food? Thank you, Mamie.
Thank you.
Thank you.
Like traditional cross-country skiers, right? They're more, the stride is more like in line in a way, because you use that toe pick and push. Versus the hockey skate is more side. Right, it's the muscles here, like a ski, like skate skiing, right? Skate skiing is like hockey skiing.
Give it like one more. Are still trickling in, but so the respiratory system. Now, the respiratory system is something we're gonna get really intimate with. So this is one system that I would kind of read that section in entirety. You'll hear a lot of the terms, well, it used to be ABCs, airway, breathing, circulation. Now there's XABC, and then X stands for exsanguination or severe life-threatening bleeding. But they're all pretty much equally as important. So airway and breathing tie in together, and this is what's kind of the primary function of the respiratory system. The respiratory system, if you really boil it down to the basic level, its function is to bring oxygen into our body and to get waste products out, specifically carbon dioxide. And there's a lot of different things that have to work together to make that effectively happen. Our body, and this you don't need to write down, but we need a specific pH of our body. And the human body's pH should be between 7.35 and 7.45. So you can see that's a very, very small margin. When that pH gets out of balance, we can go into what's called either acidotic state, if our pH gets too low, or if our pH gets too high, can get into what's known as alkalotic. So pH on a scale from 1 to 14, 7's in the middle. If the pH is small, it's acid. If it's higher, it's base or alkalotic. Now, we're not getting into acid-base balance, but our body maintains that through a couple different functions, and our respiratory function is one. Now, give you an example. So carbon dioxide, what we exhale, is an acid. So if I just said, everybody, we're going out, let's do a 5-mile run. What's going to happen in probably the first minute? Think about it. We go outside right now and start running. What are you physically going to start doing? You're going to start breathing harder, right? And we're doing that because as our cells are working harder, when we start to create more output, we start to create more garbage, waste product, carbon dioxide. And that carbon dioxide being acidic, there's sensors in our blood and in our cerebral spinal fluid that sense those subtle little changes in our body's pH, like that, and begins activating things to correct it. So we begin breathing real heavy because our CO2 levels go up, our pH starts to go down, and then our body says, we gotta blow off that carbon dioxide. So it's just kind of an example of how the respiratory system ties in with our maintaining our pH to where it should be. So the respiratory system, kind of for this portion, we'll break it down into basic anatomical locations, that we have an upper airway and a lower airway. So the upper airway is pretty much everything above the vocal cords. So your throat, right here, your larynx, your vocal cords are in there. So everything above there, upper airway, everything below that point, lower airway. The upper airway consists of your nasal cavity, so through your nose and what a lot of times referred to as a nasopharynx. So from your nose to your oral pharynx, to your pharynx, the back of your throat, to the vocal cord. So that's all upper airway. We'll talk about like obstructions, that an upper airway obstruction, I'm just using this as an example, that an upper airway obstruction typically presents with what we call stridor. And that's a so some with a partial airway obstruction above my vocal cords, that high-pitched sound, that's stridor. Lower airway obstruction like asthma or emphysema, you get more wheezing. That's more lower airway. So a lot of times just listening to a person, we can kind of start to break down where the problem is. This is a lower airway problem, upper airway problem. And we're going to get much more detailed in here. So from your trachea, you then have from your larynx, you got your trachea, your windpipe, that goes down to roughly about here. And the end of that is called the carina, where it splits into the right and left bronchus tubes. So those then go into your lung, and then they break down further and further. Almost like you pulled a tree out of the ground with a root system, right? The tree trunk is your trachea, and then the roots are your bronchus tubes and bronchioles, and it kind of gets smaller and smaller and smaller, to where they terminate at what's called the alveoli. And we'll look at the alveoli much more detailed in a little bit. I'm trying to think, I can't remember if this has a picture. I'm sorry, I'm just going to skip. I just got to look. I should have checked this out. Okay. I know it's not on the slide here, but so control of breathing. Inhalation, exhalation, right? So we got to take a breath in, and we got to push a breath out. Inhalation, when we take air in, is an active process, meaning our muscles have to contract, our body has to work. And right now we are all breathing on what's called negative pressure principle, meaning when I want to take a breath in, my brainstem tells my tells my muscles to contract. So two things primarily happen. My chest muscles contract, which expands my rib cage, makes the area bigger, and my diaphragm, which is kind of sitting like this, contracts downward. So what I do is I take this area and I increase it. And through like vacuum principle, air is then just draws in. Air wants to equal out. When I exhale, all that's exhalation is passive, meaning the muscles just relax, and I shrink that area, and that's what forces air out. So the airway is what allows that passage of air to move in and out. So when we talk about airway compromise or airway problems, that means there's some form of obstruction or blockage that isn't allowing air to get into the lungs to start to work. Now that can be from foreign bodies. When we talk about people choking, it can be an obstruction from the tongue. And I will tell you right now, nobody can swallow their own tongue. Unless you cut it off and eat it, you cannot swallow your tongue. But what happens is that tongue can relax and occlude the back of your airway and impedes any movement of air. And when someone is in a deeply unconscious state, that can happen. Where anyone ever been kind of nodding off or sleeping and all of a sudden you wake up? Because you have a level of consciousness, even though you're sleeping, that your body quickly realized my air passage isn't what it should be, and it's going to wake you up or snap you out of your sleep to correct that airway. Could be structural anatomical problems, and I guess an example of that would be you have a severe allergic reaction and your tongue swells up. So now you've got this much bigger mass taking up that passage of airflow. The cold, when you start losing nostrils, which for me, when I get sick, that is the worst part about being sick, not being able to breathe through the nose. It seems to be you lose that one, and then it works, but you immediately lose the other one, so it's kind of back and forth. But it's tough. Nose breathing is probably the most optimal because it cleans and humidifies the air before it gets in your lungs, whereas the mouth, you can move much more volume through the mouth. So, inhalation active, exhalation passive. I guess with this, your nasopharynx, there's, and I want to point this out now, you're going to see, kind of looks like these little shelves in here, right? And those are called nasal turbinates. It's basically these shelf-like structures that kind of jut out that if I cut myself right in half, and you look, you're going to see these little shelves. And what that does is when you breathe in through your nose, is it creates turbulence because the air is trying to get around these shelves, so it moves it around a lot more. And when air moves around a lot more, you've got, well, what else is in your nose? Let's think about the fun stuff. Snot, mucus, hair, and the function of that is that when we breathe through our nose, any pathogens or particulates, the hair and the snot help catch it before it gets down into your lungs. Okay, so that's the kind of the purpose that serves. But when we are doing procedures like placing a nasal airway, we're trying to pass that airway underneath those turbinates. And we'll teach you how to do that. Super easy. We can even practice on each other if you want. So once you get through the back of the airway, it actually ties in with your oropharynx. And I'm sure everyone's seen this. You get snot running for some reason, you can feel it running down the back of your throat. That's why, because there's a tube. You can't really reach your tongue back far enough, but if you lift your tongue up, first it's gonna be kind of hard, almost like bone. That's called your hard palate. If you can roll your tongue back even further, your feels start to get soft. That's your soft palate. And then you got your uvula, and then behind that is where the nasopharynx comes down. And the oropharynx, the tongue takes up a large portion of that. But then when you move back into the hypopharynx, the air, the tube basically has two spots to go, the air tube or the food tube. So the food tube, that's your esophagus, and if we look at it, it's actually, it's not an open tube, well, it's a sphincter. So it's just kind of closed. And then there's above that, there's an epiglottis, which is kind of a valve, leaf-like thing. In fact, I'll see if I can find a video at next break. Then when we swallow, that epiglottis closes over our windpipe, and that's what allows food to go. It's got nowhere else to go but our stomach. So they're both literally side by side. So if you can imagine, if someone vomits, comes up the esophagus, and we don't get it out, where else does it have to go? Into the trachea, down into your lungs. So a lot of what we do is trying to prevent that from happening. Okay, that's enough of that. I don't know why that picture's in there. That's talking about vasoconstriction, and we'll get to that with the cardiovascular system. So the lungs, your right lung has 3 lobes, your left lung has 2. I guess kind of an easy way to think about that, the heart sits center of your chest, tilted a little bit to your left. So you don't have as much room in the left lung, so only 2 lobes, 3 lobes in the right. Now the lung is, if you'd have to look it under a microscope, but millions of these tiny little air sacs, and they're called alveoli. The whole organ together has a lining around it. I think the best way to describe it, if I took like saran wrap, wrapped it around something, and then I put baby oil on that, kind of heated it up, so it makes it super, super slippery, right? That lining around your organs is referred to as a visceral pleura. Visceral means organ. And then your chest cavity itself also has a lining on that called the parietal pleura, and that's got some lubricant. So our lungs, as we breathe, are doing this, right? Every time we breathe. So can you imagine if we didn't have that lubricant and those kind of protected, that every time we took a breath and the lungs went to deflate, they would stick? Has anybody ever had pleurisy? Yeah, I guess you never have to raise your hands. I have. And it feels like every breath, someone is taking a knife, sticking it in your chest, and then taking it out. And what pleurisy is a little section of that lining through usually an infection dries out, so there's no lubricant. So every time you breathe, that sticks. And it is excruciatingly painful. So that's why that lining has to be, and it's around our abdominal organs, so you've got a visceral pleural on your liver, on your spleen, and then you have on your abdominal cavity, you got that. So those lubricated barriers, the pleura, if you will, prevent everything from sticking together. And then obviously the diaphragm. Your bronchioles. Has anyone ever heard the term bronchoconstriction? Okay. So your terminal bronchial tubes have smooth muscle on. So they can get smaller, they get bigger, based on your body's demand and needs. Your brain can control the diameter. You can't physically think to do it. It's involuntary. So none of your bronchial tubes exchange air. Okay. The only place oxygen gets exchanged is in the alveoli, and we're going to look at a close-up example of that in a second. But trachea, bronchial tubes, and then they start to break into what's called bronchioles. So smaller and smaller and smaller, and then each one ends up at basically all these alveolar sacs. Almost, I think the easiest way to think about it is like grapes. When you pick up grapes, imagine all those being alveoli and all the stems of the bronchioles. So just before those bronchioles get to the air sacs, this is where that bronchial constriction can happen. So, you've got an outer layer, and you can see this is smooth muscle that your body can constrict it, dilate it. And so when you constrict that, it's obviously harder for air to get in and out. And a lot of times you've got mucus cells in that can secrete mucus, and that's there to not only catch particulates, but if you start to get increased mucus production with narrowed airways, it's harder to exchange air. It's harder to get air in, it's even harder to get air out. Infants and children. So just kind of what this picture here. So with pediatrics, and when we talk about pediatrics, I think we're kind of talking pre-puberty. So for resuscitation purposes, when someone hits kind of the age of puberty, resuscitation is just like an adult. So a 14-year-old with an airway compromise, we're using adult-sized equipment. Okay, but less than 12, and the younger they are, the more pliable, and their structures aren't as rigid. So if I take a baby and I actually bend its head forward or bring it back too much, you can actually pinch off that airway like taking a straw and bending. So it's a little bit more subtle airway manipulation with pediatrics. And kids have a much bigger occiput, back of the head. So if you take a toddler and lay them flat on their back, their heads are almost like this, because the heads are, I shouldn't say that. I've seen some flat-headed kids, but for my grandkid being one. But yeah, if you laid them, most toddlers flat on their back, their head would be like this. So a lot of times with airway manipulation with an adult, everyone's heard of head tilt, chin lift. We move the head back to open the airway. With some kids, we actually lift their shoulder blades up. So pat under the shoulders, bring that up, and then that's better for bringing airway into alignment. We're gonna, when we get into the airway management here in a few weeks, we'll spend a lot of time on that. talk about all that. Okay. So, super generic example, but what this is showing, if you can imagine, this is the terminal bronchial coming down, this is that alveoli. In fact, did you know, if you took all the blood vessels out of the lungs and laid them end for end, the person would die? Sorry. See if Renee is awake. So generally you got a bronchial coming down, and imagine, and I don't know how many, but a pile of these air sacs kind of all going into one bronchial. Because they're almost like a ball of a sphere shape, is what we do is we increase the surface area of it, right? If they were flat, there wouldn't be as much area for gases to exchange, but because they're round and they're basically surrounded with capillaries, that's what allows us enough of the gas exchange to take place to allow for life. So you've got and I'm jumping ahead a little bit, but with blood vessels, you have a arterial end. So an artery is any blood vessel that is taking blood away from the heart. A vein is any vessel that's bringing blood back towards the heart. For the most part, arteries carry oxygenated blood and veins carry deoxygenated blood. Now, there's a few exceptions to that rule, and we'll dig into that when it's appropriate, but where arteries and veins meet is called capillaries. And capillaries are where all gas and nutrients exchange takes place. So whether it's getting glucose into your cells, exchanging oxygen for carbon dioxide, it all happens at the capillary level. Capillaries are 1 cell thick. Veins and arteries have a couple layers. So gas, like oxygen, can't go through a wall. Capillaries are more like a screen, would be the way I would describe it. So an oxygen molecule can go through the 1 cell of the capillary and go through the 1 cell of the alveoli, air sac. Let me use this. Hopefully the camera can see this. So I guess what I'm trying to describe, terminal bronchial, we've got all these air sacs, right? And now imagine this just filling up that whole lung. And hunter is probably the best that if you're ever taking out a deer and you see like where the broadhead sliced through the lung, you can actually see visually some of the bronchioles that are in there. You gotta, if you're gonna eat it, you gotta really paste it up. Okay. And lung meat is horribly good for you, I will just share that. Now, so we're just gonna take one of these air sacs. Now, imagine capillaries surrounding this entire thing, right? But for the purpose of this, I should use a different color. So here's a capillary. So you got the alveoli, you've got the capillary here. You do have a potential space, and again, this is super microscopic, right? That between the blood vessel and the alveoli, that's called the interstitial space. In fact, to jump ahead a little bit, you've only got a few different compartments in your body, or spaces. You have intravascular, that's the space that's in your blood vessel. You have intracellular, that's what's inside your cell. And then extracellular is everything that's not in your cell, not in your blood vessel. We typically call that interstitial, kind of that space in between. So this is a microscopic interstitial space. So when we breathe in, the oxygen percentage is higher in the alveoli than it is in the capillary. So your body, blood has gone through your body, come back to your heart, and now your heart pumps it to your lungs because it's been used, it's got waste products in it, doesn't have a lot of oxygen, has some. Goes to the alveoli, the blood coming through here has relatively lower amount of oxygen than what it does in the alveoli. So diffusion happens. That particles want to equal out, and this doesn't require energy, it just happens. So oxygen is going to pass through one cell of the alveolar membrane, through a little bit of interstitial space, and enter that blood vessel, that capillary. And then your red blood cells are going to grab onto that oxygen, take it back to your heart to then get pumped out to the body. So for this process to work of oxygenating our body, we have to be able to move air into the alveoli. We have to have a functioning heart to move blood past that alveoli to take on oxygen, and just as importantly, offload carbon dioxide so that we can get rid of it. Because accumulation of carbon dioxide is just as concerning as not enough oxygen. Follow me on that concept? In fact, you exhale carbon dioxide and water. So, just a slight tangent. Did you know that you can actually become loss of fluids just from breathing fast? That if I've got a fever and I'm breathing 30 times a minute for 2 days, that's a lot of water vapor loss just through breathing. And you see it when you, that's water that we exhale. So again, just kind of another example of showing it how it moves through. But it's important to understand the concept that all gas and nutrients exchanges take place at the capillary level. So to move enough oxygen, adults, they kind of know we need to have an adequate rate and an adequate volume. Two different things. So adults, typically normal respiratory rates for adult are textbook between 12 and 20. I would say right now, if I were to count respiratory rates in here, probably some are 10, 12, maybe 14. We start to see respiratory rates getting close to 20 when you're kind of at rest and in no duress. That's getting in, the term we use for that is tachypneic, fast breathing. So anytime you put tachy or tach in front of something, it means fast. Versus slow is bradypnea. I don't know if I'm pronouncing that right, that's how I see it. So you got to have an adequate rate, and you have volume is how much we bring in. So I could be breathing at 12 a minute, which is normal, but I'm just moving air, not getting it down in my lungs. So the average tidal volume of an adult is about 500 milliliters, half a liter of air. That, for demonstration purposes, of that 500 ml, so when you breathe in half a liter of air, only about 350 of that's actually being used in the lungs. The other 150 are in your trachea, in your oral hypopharynx that aren't being exchanged at all. So like when we're breathing for a person, we have to put at least 500 mLs in. We'll go through how to do that, but like when you're bagging someone, if we weren't putting enough air in, we would just be moving air back and forth in the trachea, nothing's happening in the lung. So that's volume and rate, and those two have got to kind of be appropriate. I don't like these numbers. In fact, elderly 20 to 22, pediatrics will breathe at a little bit higher rates, and every age is a little bit different. And I use charts for this. So there are 3. I would expect the respiratory rate to be maybe 18 to 24. But for adults, I kind of go with 10 to 16 is adequate respiratory rate. And then volume, we kind of gauge that by looking at how they're breathing. You know, are we seeing their chest or abdomen move with each breath? You know, so I gauge when I'm breathing for someone that we will literally see their chest When their chest moves, that means we're getting enough air into their lungs. Breathing should be regular, so there's a pattern to it. There are different types of breathing patterns, which we'll probably read about later in our book, and I'll just use some examples. So a closed head injury, someone who's got a brain injury, unconscious, they may have irregular breathing. Different terms for it, Biot, Shane-Stokes, kind of see this gradual, you know, they're unconscious, they're doing that, that's telling you that there's pressure on their brainstem that's controlling how they should be breathing regularly. Breathing should be effortless. We should see good symmetric chest expansion. And people who are struggling to breathe, they will do things to correct that without them even knowing it. So you don't need to use this, but if you've ever seen someone, well, Walmart's a good spot to see disease pathology. Someone taking a break on a park bench, and they're doing this position where they're kind of lean forward, sticking their neck out. We call this the tripod position. And what they're trying to do is structurally do everything they can to expand their chest at the optimal level. And they'll actually purse their lips to create back pressure to help keep those air sacs open. It's a real classic pattern we see with worsening of COPD, like emphysema is probably most common, or people with severe asthma attacks. Accessory muscles, if you see people like using neck muscles, you know, they're trying to use all their muscles to expand and get their chest bigger. That's accessory muscle use, and it's an impending sign of respiratory failure. Even down to infants, you may have heard sternal retractions, where if you're looking at a bare-chested infant when they're trying to breathe, you'll actually see their breastbone suck in when they're trying to breathe. This time of year, you don't have to look far. We're in croup season. Anybody got kids? Okay, croup season is here. At least it's been here for a little while, but you'll see those kids with sternal retractions, and it just means what they're trying to do is they're trying to augment or do everything they can to breathe a little bit better. And breathing should be relatively quiet, so there shouldn't be abnormal lung sounds. So when we get to assessment, we're listening to lungs, you should be able to hear you can hear air flow, but it's normal. When we start to hear or almost like if I took a bottle and shook a little water, you start to hear that rattling or wet sounds. Those all indicate potential pathology or things aren't working right. Okay, circulatory system. So circulatory system and the respiratory system kind of work hand in hand. Circulatory system is primarily your heart and your blood vessels. I talk about the heart a lot. I'm not going to tonight, but I'll put this picture back up. Can everyone see this okay? Disregard the big blue things. This is basically super generic picture of a heart. Your heart is an electrical pump. So electricity, as it moves through the heart muscle, stimulates a bunch of stuff that happen that make your cardiac cells contract. Contract, relax, contract, relax. And this is happening on average that fast. The time you're born, clear on the line. It's a 4-chambered pump. The top part of your heart, we refer to those chambers as atria. And if anyone knows anything about hydraulic pumps, the atria primarily function as priming pumps. Okay? The ventricles are kind of the workhorse of the heart. Those are the bottom 2 portions, and that's what pumps blood either to your lungs or to your body. So top and bottom, and then you've got right and left. So the right side of the heart works together as well as the left, and the top 2 work together as well as the bottom 2. So When a heart contracts, these are your atria, the top chambers, they contract, squeeze blood into the ventricles. Actually, I'll even back up. When your heart's relaxed, blood passively pours in, fills up the ventricles, fills up the atria. When the atria contract, squeeze blood into your ventricles that are already have blood in it. So what happens is they stretch out a little bit, and then the ventricles contract, push the blood out. So with that, that's kind of what's happening. The right side of your heart is kind of the low pressure system, and the right side of your heart pumps blood to the lungs. The left side of your heart, much more beefier, that's what pumps blood throughout your body. Picture here, which doesn't look anything like that. So one thing I would like you to do by next week is kind of, on a generic level, memorize how a drop of blood moves through the heart, starting with the right. So, the vena cava superior, which is above, inferior means below. So the vena cava is the largest vein in the body. So all the blood coming from your body comes through the vena cava and dumps into the right atrium. From the right atrium, it goes through the tricuspid valve into the right ventricle. And I'll even back up, valves are there to prevent backwashing the blood. Meaning, if I don't have a valve between the right atrium and right ventricle, when the right ventricle contracts, it's going to go, it's not directed. So valves open and close to direct flow. TP Ma, T is in Tom, P is in Paul, N is in Mary, A is in Adam. That's kind of the acronym I've always used to memorize the valves. So T is tricuspid, that's the first valve. So vena cava, right atrium, through the tricuspid valve into the right ventricle. From the right ventricle, it goes through the pulmonic valve, that's the P, into the pulmonary artery. So this is an artery that carries deoxygenated blood. Blood that's already been used from your body comes into the right side and is pumped away from your heart. And from that pulmonary artery, that then goes into your right and left lung. Have you ever heard of a pulmonary embolus? Okay, a blood clot occurs, that's where the blood clot is somewhere in these pulmonary blood vessels. So when the heart squeezes, you got this big clot, blood ain't getting to the lung. So that's why pulmonary embolisms are bad. So then from the lung, the blood hits the pulmonary veins, comes back to the heart into the left atrium. And through the left atrium, it goes through the mitral valve. Some books refer to it as the bicuspid, but that's your M, into the left ventricle. And then the left ventricle then pushes the blood through the aortic valve into the aorta, which is your biggest artery. And from the aorta, it goes to arteries, to arterioles, to capillaries, to venules, to veins, to vena cava. The picture even does it pretty well. You can see the left side of the heart, much more muscle to it, more mass, because again, that's got to pump blood throughout the body, whereas the right, you're only pumping it that far, from the heart to the lung. We'll talk later about heart failure and how that can, how disease here can affect that. But if anyone's ever heard of, mitral valve prolapse, which is relatively common, that's a problem with that valve. The valves, you've got structures here that can open and close those valves. Papillary muscles, chordae tendineae attached to the valves. Again, I'm not where you guys don't really need to get into that. Positions of the heart, the apex, I've always thought of apex as the top. The apex is actually the lower portion of the heart, kind of the pointy portion. I'm going to back up just a little bit too. So, coronary arteries. So the heart, again, the heart also needs blood supply. needs a lot of oxygen and a lot of nutrients because it's constantly working, that it doesn't just get the blood from inside. It has to be fed blood from the outside. And that happens through the coronary artery system. So the coronary arteries originate from the aorta just above that aortic valve. And they actually fill passive. So when the heart contracts, the aortic valve opens, blood whooshes up through the aorta, actually just bypasses those coronary arteries. Then the heart relaxes, the aortic valve slams shut, blood sloshes down, and then passively fills those coronary arteries to feed your heart muscle. So like when we talk about heart attacks or coronary occlusion, it's a blockage of that blood vessel. And when we have a blockage of a coronary artery, everything past that blockage can't get any blood, oxygen, nutrients. And when that happens, the heart muscle begins to die, and that's what we call a heart attack or myocardial infarction. And infarction means tissue death. Tim, anything else EMR-wise with the heart for now?
No.
We're gonna, especially when we talk about cardiovascular, we get deeper. But so the aorta, again, big, basically goes down kind of the center of your body. So you got your aorta comes out of the heart, your thoracic aorta, that's the aorta that's in the chest cavity, goes opening through the diaphragm, goes into your belly. That's called your abdominal aorta. If anyone has ever heard of like an abdominal aortic aneurysm, the AAA, that's where the problem is. And then down in your pelvic girdle, it actually splits down each leg to your femoral arteries, which a cut to a femoral artery can be immediately threatening to life. You can lose a lot of blood really fast through that. Those arteries will all eventually terminate at capillaries, turn into veins, and then come back to your body. Now, the big difference between arteries and veins is arteries actually have a couple layers to them. They have an outer layer, they got a middle layer, and an inner layer. The middle layer in an artery has smooth muscle. That's what allows those vessels to constrict or to dilate. So you ever sit in a hot tub? What's your skin look like? Or a sauna? What color does your skin get when you come out? Pink, red, right? Because you're in a hot tub, your body's warming up, so what happens is your blood vessels dilate to allow more cooling. Now, if you go outside, working outside, your hands get white, okay? What happens there is the blood vessels constrict to try to preserve warmth and blood supply in. So your blood vessels constantly through the day, get small, get big, and it's done with smooth muscle. Veins don't really have that ability, so veins don't necessarily contract and dilate, or if they do, it's very small. But veins have valves, kind of one-way valves, that like a check valve, that as blood moves through, it's being pushed from the arterial side, whoosh, 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 that those valves prevent the blood from just sloshing right back. So it helps kind of maintain pressure. If you're ever around the ambulance and you see them start an IV and they say, I'm up against a valve, that means that catheter is kind of at that valve, and that valve's sticking a little bit and won't open, so they can't get it the fluid to flow. It's kind of a tricky thing, but that's what they're referring to. So there's kind of the good external picture of the heart. And really, to break it down, you have two coronary arteries. You got a right and a left. Anyone ever hear of the widowmaker? So the widowmaker is kind of this guy right here, this anterior descending, and it's not really important for you guys to understand the coronary anatomy, but the left coronary artery supplies a lot of your left ventricle. And remember, when we say that left side of your heart is what's pumping blood throughout your body. So that's your main pump. And if you lose that pump, bad things happen pretty quick. So that's why they call it the widowmaker. Any occlusion in that left coronary artery, you're kind of blocking the workhorse of the heart. spent a lot of time on that already. It's just basic electricity. So in the heart itself, you've got, obviously it's primarily cardiac cells that have the ability to contract, but you also have pacemaker cells, because electricity is essential to initiate that contraction of that muscle, to allow your heart to beat. So for your heart to work, you gotta have cardiac cells that are getting a lot of oxygen and glucose, because they're working constantly. And you have to have an intact electrical system to initiate that contraction. So the heart is set up where you have a primary, what's called pacemaker site, which is kind of sets the pace of the heart. That the normal heart should be between 60, textbook is going to tell you 100. I'm just going to teach. Okay, here's where someone had to pick a rate at some point, so they said, we're just going to pick 100, between 60 and 100. And I got to go off on a little rant about this, because you're going to see it and feel it. Generally speaking, the average heart rate should be 70s, 80s, okay, and then that's at rest. When your heart rate when it goes past 90 beats a minute, you are transitioning into tachycardia. And there are a lot of things that are concerning, and that tachycardia, that increase in heart rate, is often an early sign that something bad is happening. So we shouldn't take somebody who's got a pulse of 96 and say, well, it's between 60 and 100, it's normal. No, that's a big red flag. So I always say 60 to 90 is really, when we're out in the field assessing, even if it's getting close to 90, I start to ask more questions. But 60 to 90, textbook, it's going to be between 60 and 100. Some people can actually have slower heart rates. That it's not uncommon, especially if someone's super active, exercising a lot. You're probably going to see heart rates in the 50s, sometimes in the upper 40s. But unless they're like super active, generally heart rates start to get in the 40s. We start to see things that they can't generate enough cardiac output. So we start to have manifestations of calls. But getting back to the electrical system, so that primary pacemaker site, that's called the SA node, which stands for sinoatrial node. It's kind of located at the junction of the inferior or superior vena cava and the right atrium. That's what generally sets the rate. So that impulse goes there through some kind of pathways to allow rapid conduction of that electrical impulse through the top chambers, and then it all collects at what's called the AV node, the junction. That's kind of in the center here, right in here. That electrical impulse is delayed there for a couple milliseconds, okay? And the reason that's delayed is that's what allows the atria to squeeze blood into the ventricles, allows that atrial kick, we call it. That if we didn't have that delay, we just get this, where they're both kind of squeezing at the same time. So you need that brief delay to allow the priming pumps to put blood into the ventricles. Milliseconds. And then after that, the impulse is rapidly sent down through the ventricles, and they contract then from the bottom up. If for some reason that site fails and quits working, the AV node will pick up. It's a little bit slower than what the SA, so now you might have a heart rate between 40 and 60, but it's a backup. So let's say that the muscle up here, they're having a heart attack and it's not getting any blood supply. So if that muscle's not getting blood supply, the pacemaker site's not getting blood supply, and it just quits working. Then the junction picks up slowly. If for some reason the junction fails, the ventricles have the ability to also beat without getting innervated from above, also at a much slower rate. So as you go to backup, it becomes less effective, but it can buy you time. Okay? So like when people are looking at an EKG and they're trying to determine what the rhythm is, we're looking for each of those impulses manifest on that waveform somehow. That again, this is not an EKG lecture, but everybody should recognize something like that. That's like an EKG beat. This is a normal beat. So all these correspond with how that electricity is working in the heart. This first little bump corresponds with the impulse coming from that SA node going through the atria. Then you see there's a little pause where nothing's happening, and then you get this big spike. That spike is corresponding with the electricity going through the ventricles. And then you get this little wave afterwards, and what that is showing is that the heart's resetting for the next beat. So that's kind of trying to identify the rhythm. I don't need to break it down much further than that, just know that that corresponds with how that's working. Blood, also, I forgot to mention, also a important component. So with the circulatory system, I think I said before, heart and blood vessels, again, it's like a pump. So you got a pump, that's the heart. You've got the vessels are the container, and the blood is the fluid that carries it. So if I drew a vial of blood out of somebody and I spun it, all the elements of your blood are going to separate. And primarily what we see, and this is kind of breaking it down, is you got red blood cells. Red blood cells' primary function is to carry oxygen. So when you take a red blood cell, there's actually a little hemiprotein or a protein on the red blood cell called hemoglobin. So if anyone's ever heard of, I'm getting my hemoglobin checked, that's kind of what they're looking at. How much, what's my ability of my red blood cell to carry oxygen? That's what they're checking with hemoglobin. So someone who's bleeding out, they have less ability to carry oxygen. And remember, every system in your body needs that oxygen in order to work. When we put we'll learn about I'm sure everyone's seen the pulse oximeter probe that we put on someone's finger and we get a percentage. That's measuring what percentage of that red blood cell has oxygen bound to it. So red blood cell, imagine a bunch of oxygen molecules that basically get attached and go along through the rod. White blood cells' primary function is to fight infection or pathogen. Platelets, those are elements in the blood that are responsible for clotting. So you cut yourself, you bleed a little bit, put some pressure on it, take your hand off, it's not bleeding anymore. And then you just scab. Platelets start that. Platelets kind of all clump together to form that clot. And plasma is essentially the fluid that carries that blood. Not really water, but similar to it. And there's some other minor little stuff in the blood that they can check, but for the most parts, those are your four big components. So how do we check the adequacy of your circulatory environment? Well, a few things we look for in patient assessment. Number one, skin color. Skin color is huge. Has anybody ever seen someone that looks really pale? So what's happening there is people get pale for a lot of reasons, right? And I'm not talking just haven't been in the sun or like Irish pale like me. But I mean, when you see someone who's pale, they start to look like that refrigerator, their skin. And pale, or that pale color of the skin, I start to think that the body is trying to shunt blood to the vital organs that it needs. Okay, so for example, I'm bleeding internally, and I'm for some reason I don't have the volume or I can't generate the pressure to get blood to my brain, to all my organs. So your body senses that pretty quickly with more receptors. And it's going to start to make some changes to try to shunt the blood to the core, if you will, where it's needed. And one of the things your body knows is that I my skin can go without blood supply for a couple hours. So I'm just gonna shut that off. So it'll actually take all the blood vessels that feed your skin, clamp it down. That's when skin gets pale. People also get sweaty, and another part of your body recognizes your endocrine system will secrete adrenaline, which adrenaline is what causes the blood vessels to constrict, but it also makes you sweat. So that pale and sweating there's a difference between sweating and what we call diaphoresis. That's another term you're gonna hear, and that's basically sweating when you shouldn't be sweating. Pale skin, diaphoresis, super concerning. It's not important for us to figure out exactly what's causing it. A lot of things can cause it, but we gotta start assessing the circulatory system. So skin color tells us a lot. Presence or absence of pulses. So the three primary spots that we check for a pulse, number one spot is the radial pulse in the wrist. And it's on the thumb side, if you run your fingers down, kind of a soft little spot, you should be able to find pulses there. Now, get to know where your pulse is, because pretty soon we're gonna have to be finding other people's pulses. The next spot, which we don't do very often, especially if someone's conscious, is the femoral pulse, is down in the groin. This is something you can practice on your own time. Yourself, partner. But you get down in the groin, you should be able to feel pulse, and it's a pretty good pulse location. And then the last spot is the carotid pulse up in the neck. The carotid arteries run right alongside the trachea. So I'm checking a carotid pulse, I actually put my fingers, I slide them down along the windpipe to feel for a pulse. As blood pressure drops, we start to lose pulses that are further away from the heart. So, for example, feet. My blood pressure starts to drop below 80. I'm probably not going to find pulses in the feet anymore. As it gets lower, you start to lose it. There used to be a saying that you lose the wrist first, then the femoral, then the neck. That's kind of not. It's not very accurate, so we don't really teach it. But if I don't have pulses in a wrist, so you're talking to me and I grab your pulse in your wrist, that's telling me your blood pressure is too low. So I'll check in your neck to make sure I get, well, obviously if you're talking to me, there's a pulse there. But I'll start to lay you flat to do what I can to restore pressure. Blood pressure, first off, blood pressure is relative. So everyone tells you a normal blood pressure is like 120/80, and I might be jumping ahead a little bit, but what those two numbers are, that top number is called your systolic, and systolic, we get that from the term systole, and systole is heart contraction. So when you're measuring that top number, that's the pressure that's in your blood vessels when your heart's contracting. So obviously heart's contracting, the pressure's a little higher. Then when your heart relaxes, that's diastole, that's the lower. So that's how we record it. But if I took everybody's blood pressure in this room right now, I can almost guarantee you the systolic, the top number, I could probably find almost a 50-point difference. I'd find someone who might be 88/50 and someone who might be 180/100. Every one of you are stable. No one in here is critical, and that pressure is adequate for you. So a lot of times it's relative, okay? So don't ever get in the habit of trying to say, well, a heart attack, the blood pressure will be this. No. As someone progresses through an illness, blood pressures can fluctuate over the course of 10 minutes. An example, I get hit by a car, take an impact, my liver's over here, right? Okay. Take an impact there, boom, I get a grade 4 liver laceration. My liver's just pouring blood in my belly. You guys get there, complaining of belly pain, I'm looking a little pale, might be a little bit sweaty. You take my pulse is 88, my blood pressure is 110/7. Then 5 minutes later, you repeat it, and now my pulse is increased to like 96, and my blood pressure has actually gone up to now 140/90. And then 10 minutes later, you check it again, my pulse is now 88, my blood pressure's down to 110, and then 10 minutes later, you check it again and you're doing CPR. So I have an injury, a lot of things are gonna happen, that my body's actually gonna try to correct it, right? So my body recognizes I'm bleeding, I'm losing volume, so it's gonna start bringing my heart rate up to increase pressure. My kidneys are dumping adrenaline into my system to vasoconstrict, to try to correct everything, which is gonna make my blood pressure go up, and the injury keeps going uncorrected, where now my body systems can't keep up, and it starts to go down. So you can see this. The problem is, like when I used to teach, or when I was taught, it was always, well, you know, if someone's bleeding internally, their blood pressure is gonna be low and they're tachycardic. Well, it depends on what point we get there and check them. And you could see someone deteriorate rapidly. Just because the numbers are changing, doesn't mean they're getting better, doesn't necessarily mean they're getting worse. It's just our job to note the change. And report, hey, heart rate went from here to here to here. That's just as important as it's here, okay? So we can check blood pressures, and we're gonna get into that, but blood pressures are relative, and I don't put a lot of weight into them initially. I will say, much to the irritation of my crews, but you're gonna see people do blood pressures with this blood pressure cuff that you're pumping up in a stethoscope. That's the way the first one should be done. And then you'll see people put the cuff on and push a button. Don't do that for the first one. It's estimating, I know. We always manually take a blood pressure first. But yeah, skin color, presence of pulses, and then we can do blood pressure. That's helping us evaluate. The blood pressure is kind of a reflection of what's called cardiac output. So cardiac output, basically describing, is my heart pushing enough pressure to get blood to all my vital organs? And you get cardiac output by stroke volume and heart rate. So our body can increase or decrease our cardiac output by adjusting one of those or both of them. So if you increase the heart rate and you increase the stroke volume, you're going to increase the cardiac output. Or put it in perspective. So stroke volume is the amount of blood our heart squeezes on one beat. To do that, you've got to have good heart muscle. And like kids don't have that muscle development yet. So you take like a 4-year-old. That a 4-year-old can't really increase stroke volume. What they can do is increase the rate. So kids, tachycardia is much more, we see it a lot quicker than like an adult, okay? But you can only increase to a certain point. You know, eventually my heart rate, if I put my heart at 220 beats a minute, yeah, the heart rate's going up. You think, well, that means cardiac output went up. Well, now it's beating, we kind of went past that tipping point where it's beating so fast, it doesn't have time to fill with blood. So now we're just starting to cavitate and just push. This is a lot of talk. I've gone way over. You guys want to take a quick break and then we'll wrap up? Okay, take one more break. I apologize for going so long. Okay, please everybody know that this is not the last time we're going to talk about things like the cardiovascular system, respiratory system. We get those two are probably the biggest systems that we need to know, and we'll spend a lot more time with them as we go. Probably the next biggest one is the nervous system. We don't have to get as in-depth with this, but so I'll even back up. We talked about the skeletal system, muscular system, cardiovascular, respiratory, nervous system. So all of these systems are intertwined, but yet they're separate. It's probably the best way I can explain it. But nervous system does a lot of functions to control. It's basically kind of a control center. And you'll hear me use this term a lot throughout the class, is neurohormonal input. So all of our body systems, if you kind of imagine that they work at the same speed, but sometimes the system's gotta work a little more than this system. So what turns up the volume, turns it down? The nervous system, that's your neural input, and then hormonal, specifically like hormones your body makes, like adrenaline probably being the biggest one. So that's in a combination of nerves. For example, I'm out for a walk in the woods and I come up over a hill and there's 6 wolves standing there, 3 feet away. I either got to fight them or run away from them. So things are gonna happen in my body to make me do that better than I would without it. And that requires stimulation from my nervous system and a dump of some adrenaline to allow me to do that. Structural division, so structural, there are basically 2. You got your central nervous system and peripheral nervous system. So central nervous system is your brain, spinal cord. All the nerves that come out of your brain or your spinal cord, that's your peripheral nervous system. So we kind of have a close-up of the brain. To break this down a little bit, this little section here, when we talk about your midbrain, brainstem, that's what that is. So that part, that's the part that controls all of your kind of essential involuntary functions. Your heartbeat, telling you to breathe. A lot of this involuntary stuff we can't control. So for example, you could physically hold your breath until you pass out. But when you pass out, that part of your brain takes over and makes you start breathing again. This part of your brain, generally referred to as the cerebrum, this little part back here is known as your cerebellum. Cerebrum, thought, emotion, memory. The cerebellum's primary function is balance, motor control. So if you've ever heard the term like posterior stroke or cerebellar stroke, that's a stroke to this, you lost blood supply to this part of your brain. So when we do our stroke scale, which I'm jumping ahead a little bit, where we test can they move one side of their body, can they smile, can they talk, they might be perfectly normal. If it's a posterior stroke, it affects their movement, balance, coordination, even where the last posterior stroke, I see him talking to me normally, can move arms, legs, but says it looks like the room is upside down. Like, looks like you're walking on the ceiling. And it was just because that portion of the brain was affected. No, I don't want to jump, I don't want to go on that tangent. We'll cover it as a little later. Your peripheral system, you do have, it's kind of neat how it's set up. So the time it takes an impulse to get from your finger to your brain, can be super fast, right? But our body's got these kind of relay systems that make it even faster to prevent us from getting hurt. Like the example here is you touch something that's hot, and you're able to quickly pull away. So you touch something that's hot, your arm's pulling away before that signal's even gotten to your brain. The spinal cord actually has ascending, descending tracks. So it's almost like a highway. In the right lane, all the impulses going that way. In the left lane, they're all going this way. But these little ganglia or relay stations are what allow that rapid action to take place before your brain registers. And think if we didn't have that, you would sustain a significant thermal burn without that ability to pull away quickly. So structural divisions, central nervous system, peripheral, functional system, 2 categories. Voluntary nervous system, that's what allows me to do things like this. If someone cuts me off to do other things, but allows you can think about it and physically do it. The involuntary system, or also known as autonomic, this is something we can't control. You can control things, to a point, like I said before, I can hold my breath for a little bit, and then my body's eventually going to say, nope, you're done, we're just going to start breathing for you. Within that autonomic system, there's 2 opposing systems in place. One's known as your sympathetic, and the other one's known as your parasympathetic. Now, we don't need to dive super deep into it, but the way I would describe it, your sympathetic nervous system, think of that as the gas pedal to your body. The parasympathetic nervous system is your brake. So let's go back to that scenario that you come around the corner and there's 6 wolves or a bear standing there, right? I'm sure everyone's been kind of frightened or, oh shit, or you're driving down County 8 and your car starts going, you're pointing east-west on a north-south road, the car's sliding, you know, you kind of feel that, oh shit, oh shit, oh shit. That's your sympathetic fight or flight response kicking in. Your nervous system is getting your body to either fight it or flight it, to run away. So automatically things are happening, that your cardiac output is increased, your airways open up, your pupils actually dilate so you can see a little better. All this stuff happens like that. But we have to have a way to reset it, because otherwise we would just go to fight or flight and stay there. So that's why we have that parasympathetic nervous system known as your feed or breathing system. It's just what it says. You know, it's more, we'll say, pleasurable portion. So, you know, two fun things. It's eating and breathing, right? That's parasympathetic system is in play. In fact, nicotine affects a lot of your parasympathetic receptors. When people smoke, chew tobacco, you know, you're stimulating those portions. Big charts, and I know you'll see this in the book. Just kind of break it down a little bit. So your sympathetic nervous system, I guess the control of that is located in your thoracic and lumbar spine. And your feed or breathe or parasympathetic system, the nerves basically either come out of the brain or out of the sacrum and coccyx. And they innervate, you know, they both innervate organs. Your parasympathetic nervous system and your sympathetic system innervate your heart. But it's based on what stimulus that's happening to you, what system is activated. I think I used this before. Anyone ever get up too fast and you feel a little lightheaded? So if you're in an extreme state of rest, your parasympathetic system is in control. And your body needs to do that to give all your cells rest, to allow restoration and get nutrients and build and all that good stuff. But if you stand up real fast, a lot of times what happens is we have this thing called gravity. That it's easier for my heart to pump blood this way than it is this way, right? So now I'm pumping blood against gravity. So if I get up too fast, my body doesn't have time to compensate for that pressure change standing up. That normally when you stand up, what happens without you even knowing is your blood vessels shrink a little bit. They do everything they can to maintain equal pressure getting blood supplied to everything. But when you get up too fast, there may be a delay for that sympathetic system to kick in to overcorrect that. And that's where you're not getting the adequate blood supply to your brain, you get woozy, you kind of want to go down. Consciousness is controlled by a system that's located in your brain stem, basically. So when someone has a injury to the head, or there's compression on that part of the brainstem, it can actually make you unconscious. This is why, especially for those that are here for a refresher, if you've ever been to a bad car accident, someone's unresponsive and breathing abnormally, it's because that part of the brainstem has been affected, and they can't wake up, and they can't breathe anymore because those functions are being disrupted because of damage to that brainstem. Okay. Endocrine system, basically hormones that are getting secreted by different glands. Probably your adrenal glands are the biggest ones we'll talk about in this course. The adrenal glands sit on top of your kidneys, and that's what's responsible for secreting adrenaline, also known as epinephrine, into your body. So if you've ever heard someone get allergic to bees and take an EpiPen shot, it's basically a shot of adrenaline. They're the same thing. All these glands control different things in your body. thyroid's responsible for stuff, your islets of Langerhans, that's what, those make insulin, so you can utilize glucose, but we don't need to dive into each of these glands. Just know that there's some medical conditions we go to. I don't know, well, diabetes is an endocrine issue that we run into from time to time. What's some other common? What's it?
Thyroid.
Yep, hypothyroid. Postmenopausal women tend to get, need to be on some thyroid supplement. We see that a lot. I don't know, how often, Tim, do you pick up a woman over the age of 55 that's not on Synthroid?
I'd say maybe 1 in 5 is not.
Yeah, it's so we rarely see acute problems of the thyroid and EMS, and yeah, there's
really nothing that we can do for it, even at the paramedic.
yeah, it's supportive, and we usually don't have, so like hyperthyroid, too much of the thyroid activity, they can get into what's called a thyrotoxic crisis, tachycardia, hypertension, or high blood pressure. And then on the low end, they can go into what's called a myasthenia, a coma, or they're hypothermic, bradycardic, barely breathing. But when we get there, it's mostly supportive, and we have no idea really that's what might be causing it. So we just treat the symptoms in that case. There's not a magic antidote we can do. We can't fix thyroids in the antidotes. I don't even think they can fix them in the ER. That's something that takes a lot more.
You can't fix it, period, usually.
Yeah, we can fix some of the symptoms, but, so, the endocrine system is really, well, let's see, I think it's forgive me if I get this wrong, the pituitary that secretes antidiuretic hormone. Okay, so, your pituitary gland, somewhere up here, secretes a hormone called antidiuretic hormone. And diurese means to basically pee. Okay, so this hormone stops you from peeing. Now, why would you want to do that? Well, if I'm losing fluids through sweating or I'm sick, your body senses that, hey, I'm losing volume, so it sends out this hormone to tell you, hey, stop peeing. We want to prevent any more fluid loss. Okay, and a lot of times it's temporary, and then we restore our volume, and then it turns back on. When that hormone is stimulated, especially in a pregnant woman, that along with antidiuretic hormone, they start to secrete oxytocin. Anyone know what oxytocin does?
Love hormone.
Hmm?
The love hormone.
And what it makes from third trimester starts to create contractions. So if someone's getting induced in labor, to put them on some type of oxytocin derivative to make contractions happen. So you see it a lot, well, I shouldn't say a lot, but and I'm just using this as an example, a woman who's in her third trimester and she's for some reason sick, throwing up a lot, diarrhea, she's losing fluids. So antidiuretic hormone is secreted. And when antidiuretic hormone is being secreted, so is oxytocin, which then can initiate preterm contractions. So a lot of times, IV restore some fluids, fill the tank up, shut off the antidiuretic hormone, the oxytocin shuts off, and labor, the contractions stop. Just using that as an example of how the system can work. What is this getting at? Oh. Just there's going to be some receptors that we talk about. And again, there's a bunch of different receptors, but a lot when we're talking about medication that the EMR can give. So these are 4 receptors that you kind of want to know what they are. So these are located in various portions of the body, but let's start with alpha receptors. So we have alpha 1 and alpha 2. And I'll even say you don't even really need to worry too much about alpha 2. But when we stimulate these receptors. This is what happens. So alpha-1 receptors, when they're stimulated, it causes blood vessels to constrict. So if I give someone epinephrine, that is an alpha-1 agonist. An agonist means to stimulate. So if I give someone epinephrine, it's going to constrict the blood vessels, okay? Alpha-2, which you don't need to know, but alpha-2 is inhibitory, meaning it stops it from contracting. The EMR really doesn't need to know about alpha-2, but I'll give you an example. If I took an EpiPen in my fingertip, that epinephrine is going to constrict all that blood vessels in my fingers where my finger doesn't get blood supply for a long time, and can quickly become necrotic and just die. So if you get epi into an area like that, you have to go to the hospital and they inject it with an alpha-2 agonist to dilate those blood vessels. Just as an example, okay? We're not going to do that in this class. We need to make sure that all of our EpiPens are trainers and not actual. This has happened in tech schools that instructors have thought we were demonstrating or perpetual independence, but we're not going to do that. I'll make sure. Okay, so alpha-1 vasoconstriction. That's what you got to remember. Otherwise, the beta receptors, there's beta-1 and beta-2. Beta-1 receptors are located in your heart. Beta-2 receptors are located in your lung. Easiest way to remember that, you have one heart and you have two lungs. So when I stimulate beta-1 receptors, or I give a beta agonist, like epinephrine, epinephrine is an alpha-beta agonist, so it stimulates all three of those receptors. If I give you adrenaline, my heart rate goes up, my force of contractions go up, everything speeds up, okay? Beta-2 receptors located in your lungs, when I stimulate them, they bronchodilate, make my airways bigger. So epinephrine, and I use this, jumping ahead a little bit, but someone who's in anaphylaxis, a severe allergic reaction, what's happening is their blood vessels are dilating and their airways are getting smaller. Epinephrine does the exact reverse of that. Makes the blood vessels smaller, makes the airways bigger. So trying to remember, if we know epinephrine stimulates alpha and beta receptors, then we can kind of think about the difference between the two. Integumentary system, this is obviously the largest system, it's your skin. And the skin, we really don't spend enough time on it, but it's does so much. It's not only protection, it's the best barrier against any pathogen. So, a virus can't just crawl through your skin, it has to have a route turn opening in the skin.